Bismillahirrahmanirrahim. Assalamu alaikum. I am Professor Dr. Javed Iqbal FAROOQI, and you are watching my YouTube channel, Medicine Made Easy. Over the last 3 years, we have witnessed a paradigm shift in the global and regional approach to managing chronic hepatitis B infection. With the publication of new international guidelines, the treatment landscape is evolving rapidly. And as practicing clinicians, we need to stay one step ahead. In this vlog, I'll be discussing updates from AACLD, APASL, Chinese, WHO, and EASL guidelines, and what all of this means for clinical practice in Pakistan. So, if you are managing patients with hepatitis B, whether in a public hospital, private clinic, or academic setting, this update is for you. Let's dive into the science, evidence, and practical implications together. Bismillahirrahmanirrahim. As mentioned in the intro, topic for our today's discussion is Revolution in Hepatitis B Treatment, Key Updates from 2023 to 2025. And the main theme of today's discussion is to understand when a patient is found to be HBs antigen positive, how we will proceed. Patient comes to our clinic, to our OPD, with a lab result in his hand written HBs antigen positive. So how we will proceed? This algorithm will be the climax of our today's discussion, that when a patient is found to be HBs antigen positive, how in simple three steps we will be able to decide whether the patient needs treatment or don't need treatment. But to be able to understand this algorithm, we need to discuss few basics concepts in the protocols of hepatitis B treatment. We have seen plethora of guidelines since 2007. When almost every year, one guidelines by one of the four major societies are published, either by the AACLD, or by the EASL, or by APASL, or by WHO. And this has been the last 3 years, 2023, 24, and 25, when the guidelines in 2023 by Chinese, in 2024 by WHO, and now in 2025 by the EASL, who have resulted in the paradigm shift in the approach towards treatment of hepatitis B patients. And this vlog is about that change. So we straight away start the protocol. A patient has come to us with a report in his hand, HBs antigen positive. How we will proceed? What's the treatment protocol suggested by these three guidelines? The treatment protocol for such patient has three main components. One is assessment for treatment eligibility. You assess a patient whether the patient needs treatment or not. Second is general care measures. And third is how to initiate antiviral therapy and monitor. We shall discuss these three components of treatment protocol in some detail. First, we take assessment for treatment eligibility. It includes detailed medical history, physical examination, and then investigations. Most of the PGs and young consultants, they straight away go for investigations. But this is important that before going for investigations, you take a detailed medical history and do the relevant physical examination. The investigations broadly they are classified into two groups. First group is to know the liver status, severity of liver disease, and for this purpose we do abdominal ultrasound and we do non-invasive tests to determine liver fibrosis. And the second aim of investigations or the group of investigations is lab work to know if there is any co-infection, then to do the HBV virological tests, and third, baseline labs. So this is the whole protocol. And the first component of the protocol is assessment for treatment eligibility. And three steps I repeat: detailed medical history, physical examination, and investigations. Investigations can be classified into two groups. First, to know the liver status, and second, general lab work. Now we take the medical history in some detail. The first thing you should ask or you should assess the age of the patient. This is very important. And when we will go for the algorithm and discuss the algorithm, you will realize that the figure of 30 years and 40 years and 50 years, these are very important. What is their relevance? We'll discuss later on. Then, has the patient presented with acute hepatitis? Like jaundice, leak of hepatite, vomiting, pain-right hypochondrium, something like that with raised enzymes. Then any past history suggests of acute hepatitis in past. If the patient has no clinical evidence of acute hepatitis, then you do ask whether the patient has any episodes of acute hepatitis in past, few months ago or few years ago. Then the another important point is that when the patient has not presented with acute hepatitis, there is no history, past history suggestive of acute hepatitis. So how was the person found to be HBs antigen positive? Why? Whether he was on screening for prior to surgery, prior to blood donation, or prior to some employment, or prior to visa. So this is important. You should have some idea. Then in the detailed medical history, again, any history suggestive of liver cirrhosis, such as hepatic encephalopathy, hematemesis, and melena, ascites, at present when he is in front of you or in the past. Another point is any history of co-infections, such as hepatitis D, hepatitis C, or HIV, whether the patient has been diagnosed with such infections or treated for such infections in the past. This is again very important point. Then any comorbidities, such as diabetes or metabolic dysfunction associated steatotic liver disease. You see the medical record and you see if there is evidence or if there are any data suggestive of these comorbidities. If the patient is on immune suppression, such as long-term steroid use or immunosuppressive therapy, taking for solid organ or stem cell transplant. If the patient has extra hepatic manifestations of hepatitis B, like glomerulonephritis or vasculitis. If the patient has family history of liver cancer or cirrhosis. All these points in the medical history, they are very important. And when we will discuss that algorithm I shown you in the start, these data obtained from the medical history, these different points, they will fit into different parts of that algorithm to decide whether the patient needs treatment or don't need treatment. Next is the physical examination. You do physical examination to see is there any clinical evidence of ascites and or peripheral edema. It means established diagnosis of cirrhosis. Is there any peripheral stigmata of liver cirrhosis like clubbing, Dupuytren contracture, spider nevi, loss of axillary hair, pubic hair, something like that. Then the investigations. Intentionally, I have kept the investigation at the third level, and as the basic medical teaching, investigations always comes after taking good detailed medical history and doing relevant examination. Then comes the investigation. So please don't jump to investigation straight away. First take detailed history and all those points I have mentioned with you, I have discussed with you, then the relevant physical examination. In the investigation, as I discussed with you, has got two main groups, two main aims. So the first investigations set to know the liver status, severity of liver disease. One is the abdominal ultrasound. The first important investigation or the basic investigation is the abdominal ultrasound. In the presence of clinical features of cirrhosis, you took the history, you did the examination, and you found the patient is cirrhotic. So in that condition, ultrasound highlights the diameter of portal vein, splenomegaly, size of the splenomegaly, ascites, mild, moderate, or severe, and if any mass lesion present in the liver. So you check the ultrasound for these main 4 points. In the absence of clinical features of cirrhosis, it helps to determine if the patient's liver has become cirrhotic or not. And how you will come to know the patient has become cirrhotic? The mucosal pattern of the liver, dilated portal veins, splenomegaly, or mild ascites, which was not picked clinically. Then the second set of investigations to know the liver status is the non-invasive tests to determine liver fibrosis. And they become relevant in the absence of normal ultrasound findings. In that condition, when the ultrasound findings are normal, these non-invasive tests, they help if the patient's liver is really normal, or fibrotic, or cirrhotic. The commonly used tests include APRI, which stands for AST to platelet ratio index, and it is calculated by the freely available smartphone app. So you need two parameters for this. One is the AST and another is the platelet. And the second non-invasive test is the FIB4, fibrosis 4, and it is calculated again by the freely available smartphone apps. And 4 variables are required to calculate FIB4. These are age, AST, ALT, and platelet count. So if you have got these 4 data with you, then you will be able to calculate these 2 scores by using your smartphone. And the third one is the elastography by FibroScan or shear wave elastography. And this is very important, that what the data you get after checking the APRI, FIB4, and transit elastography. If the patient APRI score is less than 0.05, FIB4 is less than 1.45, and transit elastography score is between 2.5 to 7, this patient's liver is having insignificant fibrosis. Either there is no fibrosis or F1 or the first degree fibrosis. But when the value of the APRI is from 0.5 to 1.5 and FIB4 from 1.45 to 3.25 and transit elastography from 7 to 11, then the patient has got significant fibrosis. Remember, the WHO recommends APRI 1 to be saying whether the patient has significant fibrosis or not, but we here by and large taking 1.5 as the cutoff point to between the significant fibrosis and the cirrhosis. When the EPRI score is more than 1.5, the FIB4 more than 3.25, and transit elastography more than 11, this means the patient has got cirrhosis, though the ultrasound was reported to be normal, but the patient has got F4 fibrosis and he's cirrhotic now. And sooner or later, he is going to develop different ascites and or portal vein dilatation and splenomegaly and all that. WHO take EPRI-1 as the cutoff point between the cirrhosis and significant fibrosis, but here in Pakistan, by and large, we hepatologists take is 1.5. Another set of investigations which I discussed in the start, the lab workup. Besides the investigation to find out the liver status. And the lab work includes first to know co-infections. And to know the co-infections, you do anti-HDV antibodies, anti-HCV antibodies, and anti-HIV if indicated. And these are tested by the ELISA method. The second is the HBV virological tests. And these include HBe antigen and anti-HBe by ELISA to say whether the patient is HBe antigen positive hepatitis, chronic hepatitis, or HBe antigen negative chronic hepatitis. Then HBV DNA quantitative PCR by real time as baseline viral load for initiation and our monitoring of the antiviral treatment. This is very important that you do for either initiation or monitoring. Remember, the more than 2,000 units is the significant viral load by the WHO 2024 and now the EASL 2025, and just detected is the significant point by the Chinese 2023. Then the baseline labs. Besides those two investigations which I discussed with you, the co-infections and the HBV virological tests, the other tests, these are the baseline labs, which includes serum bilirubin, serum ALT, serum AST, serum alkaline phosphatase, chronic blood, complete blood count, blood sugar, and serum creatinine. These are among the essential baseline lab tests which you need to do. Regarding ALT, upper limit of normal we take here is 35 for in Pakistan. WHO recommends 30, but the 35 we take that, and the 25 for women and girls. The WHO has recommended 19, but by and large here we take 35 for men and 25 for women. For adolescents, this should be based on ALT more than upper limit normal on at least 2 occasions in 6 to 12 months period. Alpha-fetoprotein and PUCA in patients with cirrhosis are in males over 40 years of age and females over 50 years of age. I told you that the age is important. So if your patient is male and more than 40 years, there is no signs, clinical signs or the lab findings, ultrasound, fibroscan, they are suggestive of no cirrhosis, but the age is more than 40 years in male and 50 years in female, you need to check alpha-fetoprotein and PUCA2. Now, the second component of the treatment protocols, that is the general care measures. Once you do the assessment for treatment eligibility, now the second component is that of general care measures. In the general care measures, you do counseling on lifestyle, type of diet and physical activity. It should be balanced diet, and essential regular physical activity, alcohol consumption. They should avoid the alcohol if your patient is using that. Then you prepare the patient for starting antiviral treatment. So adherence support, you advise them, you counsel them that they should be taking their drugs regularly. And of course, risk factor for renal dysfunction and baseline renal functions if indicated. So you also check for that, especially when you are prescribing these patients TDF. Then preventive measures. The HBS antigen screening of the family and household members, the spouse, the sexual contacts, and you do the HBV vaccination for those who are found to be negative. Then the third and important component is that of initiate antiviral therapy and monitor. This is very, very important. So you initiate, either you give the TDF or entecavir or TAF in persons with osteoporosis or impaired renal functions or children and adolescents. If no access to 2DF monotherapy, then at times you may be giving these for those special groups where there is co-infections. Remember, the patient-centered approach is required with discussion between individuals and their health care providers. And once you start the patient on treatment, monitoring is very important. Every 6 months, surveillance with alpha-fetoprotein and ultrasound in persons with cirrhosis or family history of liver cancer or cirrhosis. And every 12 months, the treatment response and our disease progression, adherence at each visit if on treatment, non-invasive tests, EPRI or transit elastography, ALT and HBV DNA levels, and monitoring of renal functions or creatinine is indicated. So this brings me to the algorithm which I discussed with you, that this will be the peak of our today's discussion. Once, after understanding the basic protocols, that how we will do what we need to take the good medical history and they do the relevant examination and the relevant investigations. Then we put all that data obtained from that history, examination, and investigation to decide whether we need to treat the patient or not. So, patient found to be HBs antigen positive, either you treat that patient or you don't treat that patient. So, once the patient report is in front of you, so your decision whether you will treat that patient or you will not treat that patient has 3 steps. In the 3 steps, you decide this. What are those 3 steps that you will take, you will go through, and you will reach whether my patient needs treatment or does not need treatment? Let's see that. The first step is that you took the history, you had taken the history, you did the examination, you did some relevant investigations. So in the history and clinical examination, if there was any evidence of cirrhosis and its complications, and I discussed with you that. So here comes the importance of the history, that you had taken the history and you had done the clinical examination. You think whether, or you see whether there was any evidence of cirrhosis or its complication. Then in the investigation, you had done the ultrasound, whether the ultrasound is showing any evidence of cirrhosis, portal hypertension, or liver mass. And in the non-invasive tests which you had done, the EPRI-FIB4 elastography, you see whether my patient liver was F0, F1, or F2, F3, or F4. And you had done the PCR check, so whether the PCR was detected or undetected. If detected, then viral load more or less than 2000. This is important. So whether your PCR was positive or negative, if it was positive, whether the viral load was more than 2000 or less than 2000. And of course, the serum ALT, the upper limit 35 in men and boys and 25 in women and girls. So you take these 4-5 parameters or data in front of you. And so the first step is to collect that data, to get that data. And for this data, I repeat again and again, history and physical examination and the relevant investigation, including ultrasound, non-invasive tests, bPCR, and the ALT levels. So this data is in your hand. So the second step will be, if the data says, which you have obtained from these 4-5 different variables, if the patient has got liver cirrhosis, it means F4, or if the patient has got hepatocellular carcinoma, or if the patient is in liver failure, or if the patient has undergone liver transplant. So this is one condition regarding the liver status. Or if reactivation of HBV infection is warranted, in case patient needs chemotherapy, immunotherapy, or targeted therapy. So if your patient liver is cirrhotic, or if the patient is in need of these drugs and there is danger of reactivation of hepatitis B infection. So the second step, if in the second step, any one of these two scenarios is present, you straight away start this patient on treatment, irrespective of the viral load and irrespective of the ALT levels. Simple. In the first step, you collected the data. In the second step, you looked for these two clinical scenarios, or peculiar or special scenarios, or red flag scenarios, liver cirrhosis, or the patient is in danger of reactivation. So irrespective of the viral load may be negative or may be less than 2000, more than 2000, ALT may be normal or raised, whatever the ALT level is, whatever the DNA PCR report is, you start this patient on treatment. Okay? If none of these two is present, patient liver is not cirrhotic, there is no liver, he is not a case of liver transplant, he is not a case of liver failure, there is no HCC, and he is not F4, he is not cirrhotic clinically and on examination, and the non-invasive test suggests less than F4, it may be F0, F1, F2, F3, and there is no danger of reactivation of hepatitis B infection. So what you do then? In such scenarios, you have reports of ALT with you and you have reports of DNA PCR with you. So if your patient's viral load was more than 2000, which you checked in the first step, and the ALT was more than upper limit normal, in male more than 35 and in women more than 25, if a patient has these two criteria fulfilled, so you decide whether to treat or not. And on the other hand, the PCR is undetected and the ALT level, whatever the ALT level may be, but the PCR is undetected. So these are the two extremes. The first extreme, you treat this patient, and the second end, you don't treat these patients. I repeat again, in the first step, you had these data with you, and then the cirrhosis and the risk of reactivation, if these are there, then irrespective of the viral load and ALT, you treat this patient. If these two risk factors are not there, then you consider the ALT, the PCR and the ALT. PCR more than 2000, ALT raised, you treat. PCR negative, whatever the ALT level is there, you don't treat. So it's simple till then. But all of our patients, they don't fit exactly into these two ends, these two buckets. They are in between. And what is this? The possibilities that your patient viral load may be more than 2000, but the ALT level is within normal range. Or viral load is less than 2000, but the ALT is more than upper limit normal, not fulfilling the two criteria. Or Viral load is less than 2000 and ALT is normal. So the in between the two ends, if this is the situation scenario, so what you do, you look for these additional info. If the patient liver status was having significant fibrosis, F2 or F3, and we discussed how the non-invasive test EPRI, FIB4 and elastography tell us whether the patient liver has got significant fibrosis or not. If your patient liver was having significant fibrosis, or if there was extrahepatic manifestations of hepatitis B disease, glomerulonephritis or vasculitis, or if there was co-infection with active hepatitis D and or HCV or HIV, or if the age was more than 30 years. Remember, here comes that, more than 30 years. Or if there was family history of liver cancer or cirrhosis. All these we have got extracted the data from the history, examination, and investigations. That's the reason I told you that this is very important, that in the history, you look for the age, you take the family history of cancer or cirrhosis and any co-infections or extrahepatic manifestation. So if in this intermediate zone, if any one of these is present, you treat that patient. But if none of these is present, you don't treat this patient. So these are the three steps. In the first step, you extract the data with the help of the history, examination, and relevant investigations, which includes ultrasound, non-invasive tests, HBV DNA PCR, and the ALT levels. And then in the second step, you look for the red flags, red signs. Patient has got liver cirrhosis, tumor, liver failure, liver transplant case, or risk of reactivation of hepatitis B. You treat this patient irrespective of the viral load and the ALT. If these two risk factors are not there of the step 2, you go to the step 3. In step 3, you consider two things, the viral load and the ALT. Viral load more than 2000, ALT raised, both criteria fulfilled, you treat that patient. Viral load, basically this is the viral load. Viral load not detected, whatever ALT level is, you don't treat, you follow up these patients. But if the patient is in between these two, the green and the red, in the yellow zone, it may be either the viral load was more than 2000 or less than 2000, but the ALT was normal or ALT was raised, or the combo was the viral load was less than 2000 and ALT was normal. Then you go for additional information, liver status, significant fibrosis, extrahepatic manifestations, co-infections, age more than 30 years, or family stuff, liver cancer or cirrhosis. So in this yellow zone, if these risk factors are present, you treat that patient. If these are not present, you don't treat that patient. So this is the very practical and very simple algorithm. And I'll suggest that you take the screenshot of this, and this will help you out how to categorize your patient and decide in the 3 steps whether you need to treat that patient or not. So when to stop antiviral treatment? Another very important question. It depends upon type of therapy. If you started the patient on pegylated interferon, it's a defined duration of 48 weeks. You don't extend beyond 48 weeks. But if this was oral drugs, and this is oral drugs like entecavir, tenofovir, TDF, or TAF, then don't stop lifelong therapy in case of F2 or above. If a patient was having F2 fibrosis, F3 fibrosis, or F4 fibrosis, you don't stop. It's a lifelong therapy. You may stop in case of F0 or F1 fibrosis, provided first, HBs antigen and PCR becomes negative, and patient has received antiviral treatment for additional 1 year after that. The patient was lucky. His liver was having no fibrosis, F0, F1, and he lost his HBs antigen. His PCR became negative, and after that, the patient has received antiviral treatment for additional 1 year, then you can stop. In case of fibrotic liver or cirrhotic liver, you don't stop even if H-based antigen becomes negative, because there's a chance of reactivation of H-based antigen and reactivation of infection and worsening of the liver. Second condition where you can stop in case of F0, F1 is HBs antigen is positive, but PCR becomes negative. This is another scenario. So patient is HBs antigen positive and has received antiviral for additional 2 years after that, with persistently negative PCRs during that period. And HBs antigen is positive, but PCR becomes negative, and patient is HBs antigen negative. And the patient has received antiviral treatment for additional 3 years after that with persistently negative PCRs. So if I summarize, if a patient has got fibrotic liver, F2 or F3 or above, you don't stop. You can think about stopping the treatment provided the patient was having F0 or F1. And then the three scenarios may be present. When the patient loses the HBs antigen, as well as the PCR becomes negative. So you give 1 year additional therapy and then stop. Patient is HBe antigen positive, his PCR becomes negative, but HBs is positive, you give another 2 years. And in case of HB antigen negative chronic hepatitis B, PCR is positive, negative, but HBs is positive, so you give another 3 years. So with this, I end the presentation. I hope you have been updated enough to treat your patients properly in your clinical practice. Please do share your experience, do share your queries, and I will try to answer that in the sections of comments given below. Dr. FAROOQI signing off. Take care. Khuda Hafiz.